I just want to thank Dr. Sender for inviting me to present the clinical results of Blinatumomab. The topic that I've been assigned to address is Blinatumomab as a bridge to transplant or curative therapy. As Dr. Benjamin had presented earlier, I'm going to review 4 studies. The first one has been published, which is Blinatumomab for chemotherapy refractory minimal residual disease in B lineage ALL. And then the other 3 studies are for patients with relapsed refractory ALL. First one is a phase 1/2 study in adults. Second one is a phase 1/2 study in pediatrics. And the third study is a large confirmatory phase 2 study in adult patients with pH-negative refractory relapsed ALL. The first study for refractory minimal residual disease was conducted by Dr. Top. And the reason for the study was that the German ALL group have shown that patients who at week 16 of treatment who are MRD positive have a much worse outcome than patients who are MRD negative. 69% for patients who are MRD negative versus 26% for those who are positive. And if you exclude the patients that underwent a stem cell transplant, for patients who are MRD negative, it's 70% versus 12% for those patients who are MRD positive at week 16. The same data applies to patients that were presented yesterday in previous sessions, that patients who are MRD positive prior to transplant both have a worse overall survival and a higher incidence of relapse. In this study, they enrolled patients with B-ALL that had a hematological CR with MRD failure after greater than 2 cycles of chemotherapy, and they had to have a molecular marker for evaluation of MRD. These patients were treated with a flat dose of Blinatumomab at 15 micrograms per meter squared per day, and this had been based on prior treatment for non-Hodgkin's lymphoma. Patients were given 4 weeks of treatment, 2 weeks off. For patients achieving a molecular CR, they were able to go on and get 3 further consolidation cycles, and no patients received any further chemotherapy. There were 21 patients accrued. There were 20 out of 20 patients were evaluable. Median age was 47, range was 20 to 77. The pre-treatment MRD levels were as follows. 15 out of the 20 patients were molecularly refractory disease, and 5 patients had a molecular relapse. The breakpoint status was used TCR-IG rearrangements in 14, BCR-ABL in 5 patients, and MLL in 2. 80% of these patients achieved a molecular complete response on Blinatumomab. All the responses were rapid. all responses occurred after one cycle of treatment. And 4 patients had stable MRD, and the responses were seen both in Philadelphia positive and negative patients. With a median follow-up now of almost 33 months for all evaluable patients, the relapse-free survival rate is 61%. 9 of these patients had an allo stem cell transplant with a 65% relapse-free survival rate, and patients not receiving a transplant had a 60% relapse-free survival. And this is seen in the Kaplan-Meier plot. Okay, the second study is now for patients with refractory relapsed ALL. This was the first phase 1/2 study that was again performed for adult patients with relapsed refractory B precursor ALL. They needed to have more than 5% blasts in the bone marrow. This study included Ph-positive ALL patients who were ineligible for TKIs. It included patients with allotransplant who were more than 3 months before treatment start, no autologous HSCT within 6 months of treatment. The median age was 32, again 18 all the way up to 77. 58% had no prior transplant. 8% were primary refractory. In this study, compared to the latest study, the CR duration was divided between less than 18 months or greater than 18 months. And 6% of patients were greater than or equal to second salvage. 42% had had a prior transplant. The CR/CRh rate was 69%, with 42% of patients achieving a CR, 28% getting a CRh. There were 8% of patients who had a blast-free hyperplastic marrow. Of these, 25 patients who achieved a CR/CRh, 13 patients went on to have an allotransplant. Again, most of these patients getting a CR/CRh, most of the patients, 72% of the patients had achieved an MRD negative status at the end of cycle 1. And 88% of all responders, 22 out of 25 patients, achieved an MRD negative status. This is a Kaplan-Meier, so the median survival in months is 7.6 months, and it's not, if you censor those patients who went to transplant, there was no difference in outcome. Either for relapse-free survival or overall survival. The next study is also a small phase 1/2 study in the pediatric population. Here, 41 patients were accrued to the study. The median age was 6, with a range of 2 to 16. In this population of patients, most of the patients, 61%, had relapsed after a prior allotransplant. 17% were treated with greater than or equal to second marrow relapse without a prior HSCT. So in this study, you basically picked the worst of the worst. They tested several dose levels, and the dose that was eventually picked was starting off at 5 micrograms per meter squared for the first week, followed by 15 micrograms per meter squared for the remaining 3 weeks and for remaining cycles. And again, the CR/CRI rate was 37% in this heavily pretreated group of patients. And out of those 15 patients who got a CR/CRI, 12 out of those 15 patients were MRD negative. For the 25 patients who had a prior allotransplant, 10 out of 25 or 40% of patients achieved a CR/CRI, and 9 out of 10 of those patients were MRD negative. Okay. Then this led to a phase 2 large confirmatory study that was conducted both in Europe and in the United States and accrued 189 patients in about an 18-month period. Again, the Blinatumomab was given as a continuous infusion, 4 weeks on, 2 weeks off. Patients were allowed to get up to 2 cycles of treatment, and then were assessed for CR/CRh. For the patients who achieved a remission, if they had a donor, went on to transplant. If they did not have a donor, then they were allowed to get up to 3 more cycles of consolidation treatment. In cycle 1, for the first 7 days, patients started off at 9 micrograms per day. The key inclusion criteria were patients over the age of 18, and they were Philadelphia chromosome negative patients. They had primary refractory disease, either early relapse with a duration of first remission of being less than 12 months, relapse within 12 months of an allotransplant, and then any relapse or refractory disease after first salvage therapy. They needed more than 10% bone marrow blasts or plus or minus extramedullary disease and an ECOG performance of less than 2. The key exclusion criteria was any history of clinically relevant CNS pathology, and all patients had to have a CNS remission before being enrolled on the study. The patient characteristics, 63% were male. Of note, 28% of patients were over the age of 55. 34% of patients had a prior stem cell transplant, and 39% of patients had more than 2 salvage therapies. And more than 56% of patients had greater than 75% of leukemic involvement in the bone marrow at the time of treatment. The results of the study showed 43% of patients achieved a CR/CRh within the first 2 cycles of treatment, 33% had a CR, 10% had a CRh. Of these patients who had that had MRD analysis available, 82% were MRD negative. Of the patients achieving a CR/CRh, 32 out of 81, or 40% of patients, were able to go on to a allotransplant. The main reasons why patients did not go on to transplant were either that they had a prior stem cell transplant, age was more than 65, they relapsed prior to transplant, or no donor was available. The day 100 transplant-related mortality rate was 11%. 2 patients died of infection, and 1 patient died of graft-versus-host disease. When you look at subgroup analyses for patients over the age of 65, their CR/CRh rate was 44%. If you look at patients who have had 2 or greater than 3 salvage regimens, their CR/CRh was slightly lower. If you look at patients who've had a prior stem cell transplant, their CR/CRh rate was 45%. And if you look at patients who had less than 50% bone marrow involvement, the CR/CRh rate was around 77%. With the median relapse-free survival in months is 5.9 months for all the patients. For patients who achieved a CR/CRh in this blue line, the median overall survival was 9.9 months. As far as adverse events go, this was reported as any adverse event that occurred during the study, regardless of causality. The main toxicities that are encountered are basically febrile neutropenia, anemia, thrombocytopenia, and this occurs mostly during the first cycle of treatment. Other common toxicities is you usually get a transient increase in liver function tests that return to normal. In this list, the cytokine in this study with giving pre-medications with dexamethasone and the step up of the dose, grade 3 cytokine release syndrome was only seen in 2% of the patients. And in fatal adverse events, again, these are all events that occurred regardless of causality. When they've gone back and looked at what events were possibly related to the blinatumomab, 3 of the deaths were considered possibly related, and 1 of them was sepsis, 1 of them was respiratory failure, and another one of cerebral hemorrhage. The other main concern of blinatumomab has been neurological events. And again, the main CNS events that are seen are encephalopathy, confusional state, convulsions are seen in less than 1% of patients, and most of these are readily reversible by stopping the drug and giving dexamethasone. And they reverse within 24, 48 hours, the patient is back to normal. So in conclusion, the questions are, One, blinatumomab as a bridge to transplant. Basically, when blinatumomab is used, it has a low morbidity and mortality rate, allowing most of the patients who get a CR/CRh to be able to proceed to a transplant. If you exclude patients who've had a prior transplant, 52% of the patients who achieved a CR/CRh were able to go on to an allotransplant. The majority of the complete remissions are also MRD negative, and so far there's not been any carryover toxicity that have increased transplant-related mortality for those patients who have gone on to an allotransplant. As far as curative therapy, the only small study that has been performed would be for patients with refractory MRD, where these patients became MRD negative, were given three more consolidation treatments, and have been followed now for 2 to 3 years and have remained in remission. And the patients who went on to transplant versus those who did not receive a transplant have a similar outcome. But this was in a small number of patients and would need to be confirmed with a larger confirmatory study. The other, yesterday, Dr. Logan presented the poor outcome of patients who relapse after stem cell transplant. In patients who relapse after an allotransplant, who get blinatumomab, have up to a 45% chance of achieving a CR/CRh. The toxicity compared to giving them salvage chemotherapy is a lot lower, and the only question now is longer follow-up is going to be needed to see if any of these patients have a durable remission or not.